Hi everyone, what an absolute pleasure it is to be presenting at LowCarbUSA. I'm sorry that I could not be there in person. I guess this is the next best thing, and I do appreciate you all welcoming me via Zoom. I recently completed my PhD at the University of Sydney here in Australia, and my thesis was to investigate the practicalities and effects of low carbohydrate diets for type 1 diabetes management. Prior to commencing my PhD, I'm going to admit that I didn't know a single person living with type 1 diabetes. The reason I decided to study type 1 diabetes was because I was disgusted by the lack of research investigating low carb diets in this important clinical population. My research has now connected me with hundreds of people from across the world affected by type 1, and I am truly inspired by individuals living with type 1 diabetes, their family and support people, and the community that connects all of us. I feel it's important to start with a discussion around the similarities and differences between type 2 diabetes and type 1 diabetes. The research investigating low-carb diets for type 2 diabetes is a lot stronger than that of type 1. So identifying those similarities between the two very different conditions can help us understand how findings from prior type 2 diabetes research may be translated to current type 1 diabetes management. Type 2 diabetes is characterized by high blood glucose levels, insulin resistance, and high insulin levels indicated by the green ticks. People with type 2 are at risk of low blood sugars only if they are taking certain blood glucose lowering medications. Insulin production is typically very high in type 2. The pancreas is working at its max capacity. However, individuals experience what we call a relative insulin deficiency, where their pancreas simply cannot keep up with the high glucose demand. Absolute insulin deficiency can develop in advanced stages of type 2 diabetes, and in these cases, insulin injections may be required to help control blood sugars. As most of you will know, type 1 diabetes is an autoimmune condition where the beta cells in the pancreas have been destroyed and can no longer produce sufficient insulin. Individuals affected by type 1 diabetes rapidly experience an absolute insulin deficiency, and they must administer calculated doses of injected insulin for the rest of their lives. People with type 1 can experience both high and low blood glucose levels within a short period of time, and this is largely due to the inherent difficulties in predicting insulin requirements. Insulin resistance and hyperinsulinemia may develop in people with type 1, and this is largely due to the high quantities of injected insulin that is often used to control blood sugar levels in standard type 1 diabetes management. The primary management target in both types of diabetes is exactly the same, and that is to control blood glucose levels within a safe and healthy range. So in looking at the effect of diet on postprandial blood glucose levels, it is clear that carbohydrates have the greatest impact. Carbohydrates lead to significant hyperglycemia and larger doses of produced or injected insulin that is required to metabolize them. And that's because all carbohydrates, including both starches and sugars, break down to glucose in the blood after they are consumed and digested. As such, it is logical to propose that low carbohydrate diets might be an effective strategy for achieving glycemic control in people with diabetes. The low carb diets are nothing new. Very low carb diets were used to treat diabetes in the early 1900s. What you're looking at here are the suggested dietary requirements for a patient with severe diabetes, and this was taken directly from a medical textbook published in 1921, The Principles and Practice of Medicine by Osler and McRae. Carbohydrate makes up only 2% of total daily total energy intake, while dietary fat makes up 75%. Foods without sugar, including meat, eggs, butter, and olive oil, comprise the majority of the diet prescription, and limited quantities of fruit and vegetables were included according to one's individual carbohydrate tolerance, and this is the wording they used in the textbook. However, the discovery of insulin and subsequent advances in insulin delivery systems and glucose self-monitoring technologies, which are all fantastic, allowed individuals with diabetes to employ more flexibility with their dietary intake, and strict low carbohydrate diets are no longer required, let alone routinely recommended in standard diabetes management. Currently, individuals with type 1 are advised to practice carbohydrate counting and to follow a high carbohydrate diet. Carbohydrate counting is a technique used to estimate the carbohydrate value in different foods to predict those postprandial rises in blood glucose levels after meals and snacks. And the goal here is to calculate the corresponding insulin dose required to maintain healthy blood sugars. National authoritative bodies like the NHMRC also recommend that individuals with type 1 diabetes follow the same dietary principles as people without diabetes, and this involves consumption of a high carbohydrate diet in which 45 to 65% of total energy intake comes from dietary carbohydrates, and this is consistent with national dietary guidelines. A major problem with this is that national dietary guidelines are not designed to be used by people with medical conditions. When you look at the research that underpins the guidelines, you will clearly see that people with medical conditions were excluded from participating in the studies. There is no research that supports the clinical recommendation that people with type 1 should be eating the same diet as people without diabetes and following national dietary guidelines. The inappropriateness of this recommendation is stated clearly on page 2 of the Australian Dietary Guidelines themselves. Underlined in red, you can see that the guidelines do not apply to people with medical conditions requiring specialized dietary advice. There is no doubt that type 1 diabetes is a medical condition requiring specialized dietary advice. It is an incurable chronic disease in which carbohydrate metabolism is significantly impaired. People with type 1 are physiologically different to people without diabetes, and they experience daily health challenges that have the potential to be life-threatening, of which people without diabetes do not experience. In 2020, myself and a team of researchers from the CSIRO performed a secondary analysis of the Australian Health Survey. We wanted to find out whether people with type 1 diabetes are indeed following the recommendations set out in national dietary guidelines or not. And our results did show that adults with type 1 diabetes have similar energy and macronutrient intake profiles to adults without diabetes, which are consistent with national dietary guidelines. And we see striking similarities between dietary intakes of type 1 diabetes adults living in Australia versus those living in the US. Carbohydrate intakes for people living with type 1 diabetes in both countries are equivalent to 45% of their total energy intake, and ultimately consistent with current recommendations to follow a high carb diet. So why is it that people with type 1 diabetes are struggling to achieve glycemic control targets? The average HbA1c of people living with type 1 diabetes in Australia is 8.4%. Worldwide, data from over 19 countries shows that only 16% of people living with type 1 have an HbA1c of less than 7%. And further, we have an epidemic of double diabetes, wherein the characteristics of type 2 diabetes are now being displayed in people with type 1. Traditionally, people with type 1 diabetes were lean. Insulin resistance and obesity was only associated with type 2 diabetes. However, a recent systematic review examining the global prevalence of the metabolic syndrome in individuals with type 1 showed that almost 25% were affected by the metabolic syndrome. There's other research also to show us that Australia has the highest rates of the metabolic syndrome in type 1 diabetes worldwide. So continuing to refer to national dietary guidelines to inform the diets of people with type 1 diabetes does not seem to be an effective, let alone an evidence-based strategy. Glycemic control targets are not being met, they are not even close to being met, and the metabolic health of people with type 1 diabetes is worsening. Something needs to change. I'm sure most of you here will agree that modern type 1 diabetes management should include strategies for achieving glycemic control targets with less use of insulin overall, as it is critical to address the rising rates of insulin resistance in this insulin-dependent population. Given the overwhelming evidence supporting the use of low-carb diets for improving glycemic control and metabolic health in people with type 2 diabetes, it is essential that we reconsider the use of low-carb diets in modern type 1 diabetes management. So in 2018, myself, Professor Kieran Rooney, and Professor Ron Raab published the first systematic review investigating this topic. We were fairly inclusive with our search criteria as we predicted a lack of data. We included all study designs, from case reports to observational studies to randomized controlled trials. We included all low-carb diets that were below 45% total energy intake and then categorized them into true and false low-carb diets. We found 9 studies in total, 6 of which assessed true low-carb diets below 130 grams of carbs daily or 26% total energy intake. So of these 6 studies, clinically meaningful HbA1c reductions between 0.7 and 1.3% were reported. Concurrent reductions in total daily insulin dose between 11 and 22 units per day were also achieved. So although these collective results are indeed promising, there was a sheer lack of well-controlled prospective clinical trials. The sample sizes were quite small and there was significant heterogeneity between the studies. In any case, this review brought well-deserved attention to the use of low-carb diets in type 1 diabetes management and highlights that it's certainly an area worthy of pursuing. So before diving into our own interventional study, our research team wanted to gain some real-world insights into the practical application of low-carb diets in type 1 diabetes management. We set out to learn from any groups in Australia who are already using low-carb diets for type 1 diabetes management in clinical practice. Over in Stirling, Western Australia, is the Type 1 Diabetes Family Centre, who for quite some time have been supporting patients who self-select to follow a low-carb diet to improve their type 1 diabetes management. After gaining ethics approval, I travelled to WA to collect all the relevant information that I could. This data was published in 2022 as a retrospective case series analysis, and I will share some of the main results with you now. 26 adults provided their consent to share clinic data with us and were eligible to participate. 77% of these individuals were female, and the average duration living with type 1 diabetes was 12 years. 65% were overweight or obese, reflecting the high rates of the metabolic syndrome in type 1 diabetes adults, particularly those interested in trying a low-carb diet. Now, the low-carb diet used at this clinic was a patient-led approach supported by a skilled diabetes educator and dietitian who could provide both diet and insulin management advice. Advanced carb counting was taught and recommended to account for all the carbohydrates in foods, and the average carbohydrate prescription was 63 grams per day, which was equivalent to about 11% total energy intake. Proteins and fats were both increased relative to baseline, with fat comprising the majority of energy at 64%. Estimated A1C was measured using the participants' own continuous blood glucose monitoring devices. For the 19 people with this data available, mean estimated A1C reduced from 7.1% to 6.3% across the 21 weeks. Most of the participants seeking low-carb diet support from this centre were already attempting some form of low-carb on their own. So with professional support, they were able to experience even greater improvements in their glycemic control. Time in target blood glucose range, so 3.9 to 10, improved from 58% to 76% across 19 weeks for the 9 people who had this data available. And this clearly reflects less time spent in both high and low blood sugar ranges. Total daily insulin dose reduced from 44 units per day to 31 units per day across 17 weeks for the 15 participants who had this data available. And these results are ultimately consistent with what we saw from the studies in the 2018 systematic review and highlight the unique ability for low-carb diets to improve glycemic control with less use of insulin overall. In addition to the case series, we completed 2 other studies to help us formulate the protocol for our own clinical trial. We wanted our protocol to be thoughtfully designed, well described, and evidence-based so that other research teams from across the globe would be encouraged to replicate this research and strengthen the evidence base for low carb in type 1 diabetes management. So in 2019, we published the largest systematic review investigating low carb diets for type 2 diabetes management. However, our focus was not on analyzing the results of these studies. We already have at least 6 published systematic reviews that have done this. Our focus was on analyzing the method section of the 40 successful low-carb diet interventions. This allowed us to identify a set of core components for developing low-carb diets that could be applied in both clinical practice and future research studies, including our own clinical trial. With that said, we felt the information on achieving nutritional adequacy when formulating low-carb diets was lacking. So in 2022, we published an analysis of the Australian Food Composition Database to identify the top 10 low-carb sources, food sources I should say, for each of the 27 essential vitamins and minerals. The goal of this study was to develop a set of resources that practitioners and researchers could use to formulate their own nutritionally adequate low-carb diets in research and practice. So with all of this prior research behind us, completed as a foundation, we designed and conducted a prospective clinical trial to investigate a low-carb diet in adults with type 1. Our research team was a mix of healthcare practitioners and academics from across Australia. This included myself, Dr. Helen Parker, and Professor Kieran Rooney from the University of Sydney, Professor Grant Brinkworth, a well-respected academic from the CSIRO, Dr. David Lim, a GP based in Sydney, Dr. Kevin Lee, an endocrinologist based in Brisbane, and Amy Rush and Rebecca Johnson from the Type 1 Diabetes Family Centre in Stirling, Western Australia. So the primary outcome of our study was HbA1c, and secondary outcomes were glycemic variability, frequency of hypoglycemia, total daily insulin, and quality of life. Now, given there are an extraordinary number of factors that influence glycemic control in type 1 diabetes management, a single arm within patient intervention study where participants would act as their own controls was deemed to be the most appropriate study design for what we were trying to investigate. The timing of our study wasn't ideal. We commenced this trial in July 2021, just as Sydney had gone into a complete lockdown, and I believe the rest of the world had too. Our original plan was to run the study from the new research clinic at the University of Sydney, but we had no idea how long these lockdowns were going to last, and we really did not want to delay recruitment. So we made the last minute decision to utilize a fully remote care delivery model wherein participation was completely online. Now, this has been done before in low carb studies for type 2 diabetes. Most of you will know about the Virta Health study, but it has never been done in low carb studies for type 1 diabetes. So despite the challenges of COVID-19, national lockdowns, and last-minute changes to our study protocol, we successfully recruited our target sample size of 20 eligible adults living with type 1. This is an overview of what participation in our study looked like. It started with a 4-week control period where participants were instructed to maintain their habitual diet, exercise regime, and type 1 diabetes management. To be eligible for the study, people had to be habitually consuming over 150 grams of carbs a day. So this is the diet they continued to follow during the control period, and this is the diet that acted as our higher carbohydrate comparator. Participants then moved straight into the 12-week low-carb diet intervention. The carbohydrate target started at 50 grams of carbs a day, and there was then opportunity for participants to increase or decrease this within a broader range of 25 to 75 grams of carbs a day, and that decision depended on their blood glucose levels and, of course, their dietary preferences. This is what we call an adaptive carbohydrate prescription. Recommended sources of minimally processed protein foods and fats could be consumed to satiety, but myself, the study dietitian, guided participants with recommendations for meeting individual energy and nutrient requirements. Participants received educational booklets, sample meal plans, and had fortnightly sessions with me via Zoom for guidance, support, and accountability. Now, here's one of the sample meal plans from the study. Each meal included about 150 grams of animal-based protein foods like eggs, salmon, yogurt, cheese, meat, and fish, as these are some of the top sources of essential nutrients. Participants were also encouraged to add healthy fats to help meet their energy requirements. This was not a calorie-restricted study design, so they're encouraged to consume foods like avocado, olive oil, butter, and cream. It is worth noting that most participants did admit to feeling hesitant about the low-carb diet at the start of the intervention. Restricting to just 50 grams of carbs a day was a little confronting. This is understandable because these participants had been living with type 1 diabetes for an average of 21 years, and their prior dietary education had been almost solely focused on the importance of including adequate carbohydrates with every meal and every snack. However, after seeing this meal plan, receiving practical advice, and learning more about the science and theory behind low carbohydrate nutrition, participants did feel more confident and were keen to get started. 16 participants completed the study in its entirety, including the 4-week control period and the 12-week low-carb diet intervention. Of the 4 dropouts, 1 participant was struggling with pre-existing mental health issues. 1 participant reported a lack of time to commit to the study requirements. 1 participant reported difficulty making insulin adjustments on a low-carb diet, and 1 was simply lost to follow up. Nevertheless, we were quite happy with 16 completers, especially given the challenges imposed by COVID-19 and those lockdowns. Now, of the completers, the average age was 43 years, 50% were female, the average BMI was in the obese category, 31.8, and the average duration of diabetes, as I said, was 21 years. Here are the individual changes in carbohydrate intake before and after the low-carb diet. The starting intake of carbohydrates, as you can see, was 214 grams per day. By the end of the 12-week intervention, participants reduced their intake of carbohydrates to 63 grams per day. All participants reduced their intake of carbs to some degree. You can see some more than others, with most participants falling within that target range of 25 to 75 grams per day by the end of the 12 weeks. Here are the individual changes in HbA1c before and after the low-carb diet. Mean HbA1c levels started at 7.7%. After the 12-week intervention, HbA1c levels dropped to 7.1%. The 0.6 percentage point reduction is both statistically and clinically significant. HbA1c reductions as low as 0.3% have been shown to reduce the risk of diabetes-related complications, including heart disease, kidney disease, blindness, and limb amputations. Further, the target for diabetes management is to achieve an HbA1c of 7% or less. Our participants moved substantially closer to this in just 12 weeks, with 44% of participants achieving this target by the end of the low-carb diet intervention. And remember, this is after 21 years of living with type 1 diabetes. What makes the improvements in HbA1c even more impressive is that participants concurrently reduced their total daily dose of insulin. Insulin use reduced from an average of 65 units per day to 49 units per day at the end of the 12-week diet intervention period. Again, consistent with what we see in those other studies investigating low-carb diets for people with type 1. Here is the table of all our main clinical outcomes. Aside from improvements in HbA1c and total daily insulin, our study also demonstrated statistically and clinically significant improvements in glycemic variability outcomes, fasting blood glucose levels, diabetes quality of life, body weight, and body mass index. There were no significant changes in the negative direction for any outcome, and that included frequency of severe hypoglycemia, blood pressure, and blood lipid profiles. And during the low-carb diet intervention period, there were no adverse events reported. So overall, our results certainly support the use, feasibility, and safety of low-carb diets in type 1 diabetes management. We followed up with our participants another 12 weeks after the intervention period had finished to see what diet they were choosing to follow and also to measure some of the main outcomes again. It's worth noting that no healthcare practitioner support was provided to participants during this follow-up period, and participants were instructed to follow whatever dietary approach they wanted to follow. Many of them chose to stay low carb, but they did increase dietary flexibility somewhat. So looking at the group of completers, you can see the reduction in HbA1c was sustained at 7.1% at the 24-week follow-up time point. Total daily insulin dose increased slightly from 49 units to 53 units per day, and this did correlate with a slight increase in carbohydrate intake at the 24-week follow-up. Overall, it's positive to see that the improvements in HbA1c can be sustained beyond the intervention period, but these results suggest that ongoing healthcare practitioner support and guidance beyond 12 weeks is likely an important factor for sustaining a well-formulated low-carb diet and perhaps also for achieving further improvements in glycemic control. Although our study was small, it still makes an important contribution to the field. This table provides you with a summary of the prospective international studies, excluding case reports, that have investigated true low-carb diets for longer than 2 weeks in people with type 1 diabetes. So including our study, there are 5 studies in total, with 3 of them being single-arm intervention studies and 2 of them being randomized controlled trials. The sample sizes range from 8 to 48 participants, and the follow-up periods range from 2 weeks to 4 years. When you include the retrospective case series analyses and the Harvard survey published in 2018, you can see the evidence base is a little more impressive. I truly hope these collective findings attract the interest of larger research teams from across the globe who can further investigate the use of low-carb diets in people with type 1. We need to work together to continue to strengthen the evidence on this topic and to inform clinical practice guidelines for type 1 diabetes management. To finish, I have provided some recommendations for future research. A randomized controlled trial that controls for diet quality would be an important next step. Our clinical trial examined a low-carb diet prioritizing minimally processed foods. Diet quality is a factor that we all know impacts glycemic control and insulin sensitivity. So comparing the effects of a low-carb diet based on minimally processed foods with a high-carb diet of the same nature on type 1 diabetes management outcomes would be very interesting. We also need trials that specifically investigate the efficacy of sustained nutritional ketosis in people with type 1. Our study found some participants going in and out of ketosis throughout the intervention, but our carbohydrate target was not low enough to achieve sustained ketosis, nor was this our intention. Further, we need prospective clinical trials that extend beyond 28 weeks to better understand long-term changes in type 1 diabetes management outcomes with low carb, but also to measure hard clinical endpoints such as cardiovascular disease events. That's it from me for now. If you'd like to contact me for further information on anything I have discussed today, please don't hesitate to send me an email or connect with me over on Instagram. I love receiving stories from people who have changed their diet for the better and experienced life-changing results. It truly never gets old. Thank you so much.